So here, all right, starting with our presentation for today. Our topic for today is capnography. I'm Dr. Mitanshi Jain. Uh, so concept of capnography is based on the monitoring of concentration and partial pressure of carbon dioxide in respiratory gases. It provides a graphical representation called a capnogram, which is essential for assessing ventilation, perfusion, and metabolism. Widely used in anesthesia, critical care, and emergency medicine. So the concept arises because the way we monitor oxygen through pulse oximetry, that is for seeing the saturation in our RBCs and seeing how the oxygenation is being affected at a cellular level. The same way we have to monitor CO2 levels also for metabolism, especially when you are giving general anesthesia to the patient. You are intubating the patient with a tube and you are taking all of their respiration in your hands. There is mechanical ventilation given to the patient via anesthesia machine. And so you have to make sure the adequate expiration of CO2 is also taking place, while adequate oxygenation also of your uh, tissues is taking place by giving oxygen to the patient. So you see the airway here. So the airway here, the oxygen is traveling here and it is going here through the tracheobronchial tree and perfusing the alveoli. And CO2 is being transported back from the alveoli and it goes back to the tracheobronchial tree. It comes out of the trachea and it is exhaled out from your nose. So the area which is not ventilated, the alveoli which are not perfused by the arterioles and the capillaries, they are not getting perfused adequately. And this is known as this area of gases are known as the dead space gases. So in this area, the airway is containing dead space gas, but this area, the alveoli containing area, contains the alveolar gases, which is adequately perfused and which is adequately ventilated as well. So going to the concept of the capnography, uh, this is why it is very important to monitor CO2 levels so that we know that the metabolism is getting adequately done and perfusion is getting adequately done. And uh, this brings us to the principle of capnography. The principle is based on the infrared spectroscopy. Here, the CO2 is absorbed at infrared light by the infrared light at specific wavelength of 4.3 micrometer. The amount of absorption is proportional to the concentration of CO2. A sensor detects the absorption and converts it into a waveform. There are two main types of sensors, mainstream and side stream. Just a minute. Mainstream and side stream. Like you see here, the CO2 sensor is inserted between the breathing circuit and the endotracheal tube. Endotracheal tube and the breathing circuit is containing the mainstream CO2 sensor. There is no gas removed from circuit. And earlier sensor, they were very heavy and they used to increase the dead space in the intubation circuit, and they might get damaged or lost, and they are very expensive. So mainstream circuits are very rarely used, while the side stream circuit is a very big component of monitoring in our anesthesia. We use it in our hospital setup as well. The side stream setup consists of attaching a 6 feet monitoring line, which is which is attached to a sampling adapter between your ET tube and the circuit. And CO2 sensor here is constantly aspirating gases from your circuit and showing you a real-time capnograph. But it has a delay of 1 to 4 seconds, and that is why it is not very real time as compared to a mainstream CO2 sensor, and it is easily adapted to a non-intubated patient. Now we talk about the types of devices used to monitor EtCO2. One is semi-quantitative capnometry and the other is quantitative capnometry. In semi-quantitative, we are not getting precise value, that is the amount of CO2 that is exhaled out, But there can be a color change which will tell us if it is in a normal range or it is going to a higher range. So the color is changed from purple to yellow. While in quantitative EtCO2 monitor, uh, it will show you a waveform as well. The amount of the value of EtCO2 levels that are being exhaled out, and also your respiratory rate can be monitored in a quantitative waveform. So it comes to clinical uses of capnography. What is the need of capnography? Why do we need a capnography? So first thing that we consider, it's the golden standard of monitoring ET tube placement verification. It is also used for monitoring of airway and ventilation during sedation. It will let me know if my patient is not expiring CO2 well, and if it is going in a very deeper plane of anesthesia, I might have to lighten the plane of anesthesia to maintain his respiratory airway reflexes. Then to detect breathing and apnea. It's very important. If I have not secured the airway of the patient, I will have to keep him breathing, and it will let me know if the patient is going into apnea. Ventilator malfunction. If my ventilator is not it's not adequate in bringing out CO2 gases adequately from the patient, it will require me to change a lot of parameters in my ventilator, and that is why ventilator malfunction detection is very easy with EtCO2 functioning. Also, it also helps in CPR. When you are giving CPR to a patient, if he starts breathing, your your immediate detector will be your EtCO2. And also ROSC, return of spontaneous circulation after CPR. If it is a successful CPR and I was able to successfully revive my patient, then it is going to let me know that my patient is now breathing well. And it also detects the prognosis. If my patient is generating adequate tidal volume, that means he does have a better chance at revival and being alive. So EtCO2 values, what is the normal range of EtCO2 values? 35 to 45 millimeter of mercury is normal. If my EtCO2 values are going above 45, that means my patient is hypoventilating. I want you to understand this is how we breathe. If I'm breathing fast, I'm not expiring adequate CO2 volumes. While if I'm breathing slow, if I am respiring out adequate CO2 volumes, that means I'm hyperventilation. It is a good ventilation, and my CO2 levels will be low in my body, and that will show my EtCO2 values are also less. That will be less than 35 mm of mercury. Now, time capnograph. This is a very important capnograph that is asked in your NEET PG. NEET PG examinations always ask you one or two questions always related to capnography, and you have to know all the waveforms that are that show the that show different pathologies and their capnographic depictions. So I want you to understand first a normal capnograph. How does a normal time capnograph look? So this is a normal time capnograph. This is not how you breathe. This is not a normal breathing patient. This is my adequately ventilated patient. And my adequately ventilated patient is having these four stages in his respiration that I am giving him via my mechanical ventilation, via the ET tube, endotracheal tube attached to a mechanical ventilator, or via spontaneous ventilation that is kept in my hands. That is what we call bag and mask ventilation. Now, the four graphs that I will first, we'll see each phase of the graph well in my presentation. But just to explain you what is happening in this graph is the first phase requires respiratory baseline, and it is not supposed to have any amount of carbon dioxide in its phase. So it contains 0 mm of mercury of carbon dioxide. Then comes, so this is my inspiration. This is inspiration happening. There is no CO2 component. I'm just inhaling oxygen right now. Okay. Then the second phase of my capnograph starts. The second phase of my capnograph has expiratory upstroke. Expiratory upstroke has my now dead space, the dead space that we talked about earlier in my PPT. The dead space gases, let me show you. Just a minute, I'll show you what I'm talking about. Here, the air is now traveling from here to here, back. So this air contains CO2, but first this part of air will travel, right? And then it will make space for this part of air to come out of my respiratory airway. So this I want you to keep in mind while we discuss the normal capnograph. Okay. So expiratory upstroke starts. Now I have started to expire. So when I'm expiring, my expiration will first contain very less amount of CO2 and it gradually increases. While in the alveolar plateau, now my all the alveolar air that was there, now all my alveolar air has come into my central airway and now it is being expired out. So this airway, this part of my hypnograph contains a lot of CO2. And this is the point where end tidal CO2, my tidal volume is now at its end capacity, and it will contain EtCO2 at its maximum levels. And then again, my breathing starts, and now again I inspire. I start my inspiration. I've expired all of my air. Now I again start inspiration. So this is here, my CO2 levels are going down and my oxygen is increasing. And here is my inspiratory value. So this is called as inspiratory downstroke. We'll understand it further with the slides. Okay, normal capnography waveform, like we discussed. A to B. A to B is my point of baseline. No CO2 here. B to C. Start of alveolar exhalation. C to D. Here it is expiratory plateau, only alveolar gases, no dead space gases, no mixture of gases, only CO2 containing air is coming here. And D is my point of highest CO2 exhalation that will give me my EtCO2 levels, that is end tidal CO2 levels. And DE is inspiration is beginning. Now my CO2 levels will go down. And E to A is again like A to B. No component of carbon dioxide is present here. Only oxygen here. All right. Okay. Phase one, capnography. Phase one. This consists of dead space ventilation, like we discussed. Here, inspiration is taking place, and only dead space gas is available here. Phase one consists of um, the ending of the inhalation and the beginning of the exhalation. Point B is the point where my exhalation will start, and CO2 is not present during inspiration, so the baseline is 0. Phase 2, here, this is known as my ascending phase. Ascending phase because CO2 from the alveoli reaches the upper airway and mixes with the dead space air. This causes rise in the amount of CO2 and is detected in exhaled air. Phase 3. This is my important phase. Phase 3 consists of alveolar plateau. Only alveolar gases are exhaled here. So the carbon dioxide from the alveoli has reached the airway exit. The exhaled air is now rich in CO2. In normal ventilation of healthy lungs, the concentration of CO2 in the air is uniform. Then comes my EtCO2. EtCO2 is the end of phase 3 and is also the end of exhalation. Termination of the breath cycle contains the highest concentration of CO2 and is called end tidal CO2, like we discussed. Here, the maximum amount of CO2 is available to me at the end of my expiration. It's very important to understand this concept. Once you understand this concept, you'll be able to answer all the questions asked in your exam. Okay. And then phase 4. Phase 4 is again descending phase. You are coming back from your expiration and you're going into inspiration. So this will have decreasing amounts of CO2 levels and it will have more amount of oxygen here, which is not detected in EtCO2. Of course, it will be shown in your oxygen saturation port. When inspiration does begin again, the amount of measured CO2 quickly drops to 0. The rapid descent to baseline is shown here between D and D. The return to baseline is called phase 4. This is my phase 4. Okay. So EtCO2 waveform assessment correlate the color with the waveform color. So AB is my baseline. This is what I want you to know. If they ask you in your exam to label what what is the phase that is labeled in the graph, you should be able to answer that A to B consists of baseline. This is your phase 1. B to C is your expiratory upstroke. That is your phase 2. C to D is your alveolar plateau. That is your phase 3. And D to E is your inspiratory downstroke. And that is your phase 4. A to B, then again I will start with my baseline. That is your inspiratory baseline. All right. So this is what you studied with your EtCO2 waveform. This is a time. This is a time capnograph. Your x-axis has time on it, and your y-axis is having CO2 levels on it. CO2 levels are measured in millimeter of mercury. Always remember. Okay. So in volume capnograph, what we do, the partial pressure of carbon dioxide is plotted on your y-axis, while expired tidal volume is plotted on your x-axis. Okay. So when my tidal volume is plotted on my x-axis, that will give me a triangular graph of two triangles that you see here. These two triangles are giving me my dead space area. Like we discussed, the dead space consists of the air that is not being perfused. There is no perfusion in those gases. It is a wasted air that you can call, that when you are breathing air till the level it goes to your respiratory alveoli is not being perfused. So not any amount of oxygen in that air is being taken up by the circulation in your body. So it is not being helpful to your body, right? It is getting humidified and it is reaching to the terminal part. That is its only role. So this is very helpful. This it is called as volume capnogram because expired tidal volume is plotted on the x-axis, and this will give me my dead space. Now there are two types of dead spaces. Anatomical dead space that I explained you right now. It will consist of nose, your nasopharynx, your oropharynx, your trachea, your larynx, your trachea, tracheal, your entire tracheobronchial tree. And that will consist my anatomical dead space till the level of respiratory bronchioles, of course. And alveolar dead space, there are also deceased patient. Now, pathological point of dead space comes in picture that alveolar dead space has consists of the alveoli that are not helpful in respiration. There are cases like basal atelectasis. There are alveoli which are not having arteries or capillaries which are helpful in the respiration. So that is what you called as shunt. That is known as VP shunt, or that is known as ventricular perfusion mismatch shunt, right? So here the ventricular perfusion mismatch, where it takes place, that area is called as alveolar dead space. Okay. So area under the CO2 curve is effective alveolar ventilation. So this area you see in orange color, that is your effective alveolar ventilation. Only this part is helpful in your ventilation. While area above the CO2 curve, yes, this is your alveolar dead space. This is indicating alveolar dead space. And a vertical line is drawn across phase 2. This you see. We are drawing a line across phase 2 such that two triangles P, this is P and this is Q, are equal in area. Okay, two triangles we are forming, and this is dividing the physiological dead space. This is entirely my physiological dead space into anatomical. This part, the left hand side of your vertical line, is my anatomical dead space, and this part, the alveolar dead space, is formed by the right side of my vertical line. This is a little higher level. I don't think this will come in your exam, but it is a good concept to learn the dead space. Okay, all right. Now, EtCO2 levels. How do you monitor EtCO2 levels and how does capnography come into the picture? How does it help you? So factors increasing EtCO2 levels. My EtCO2 shown is 42. My normal levels are 35 to 45, so I'm not worried here. 42 is very manageable. Then 17 respiratory rate, which is okay. But here, do you see hypoventilation? My respiratory rate is less. So 7 respiratory rate, that is very less to be inspiring in a over a minute, right? So only 7 times my tidal volume is being taken by the patient. Hence, my CO2 levels are increasing. Like I showed you, very less times I'm breathing. So my CO2 is getting accumulated in the body. I'm not expiring them properly. So, what are the factors increasing EtCO2 levels? Hypoventilation, that is my first cause. Then there is reduced respiratory rate, we discussed that. Reduced tidal volume. If my tidal volume is less, of course, my CO2 levels are going to increase in my lung, right? Then there is metabolic acidosis. Increased EtCO2 will lead to uh, will lead to acid acidosis. So that will cause metabolic acidosis. And then increased cardiac output, increased dead space, rebreathing, hyperthermia. So when my patient is having a febrile episode, that is also the time when he won't be ventilating well. So that will also cause increased EtCO2 levels. Rebreathing. If my circle system is having a lot of circle system is something that your expired air is also given back to you for ventilation. So in that, your CO2 levels can also increase. Uh, and that you will learn with anesthesia machine. Then increased dead space, like we discussed, not just anatomical, alveolar, not just physiological, there can be a pathological dead space as well. And increased cardiac output. If my perfusion is more, and my ventilation is less. So that will cause a lot of CO2 levels in my body. Okay, chalo. Then factors decreasing EtCO2 levels. EtCO2 levels are decreasing now. This is my normal capnography, like we explained, but here I'm expiring more, right? We are just washing out CO2. So much CO2 is coming out of my body. And that is why, do you see, this graph is decreasing in trend, right? So my CO2 levels are less than 40 now. That is 30, which is less than optimal range, right? 35 to 45 is a normal range I want to maintain in my patient. So, what is happening here? Respiratory rate is increasing, hyperventilation, tidal volume can increase, a lot of breathing and a lot of breathing out, right? So, if you are giving a lot of volume also to the patient, so a lot of volume is being expired out also. Pulmonary embolism, right? That is also decreasing my TCO2 levels. And hypovolemia. The hypovolemia is because a lot of cardiac output, sorry, a less cardiac output in your body is not able to contain CO2 levels. So, very less CO2 levels are there in your body because the volume is less in your body. Okay, the plasma is containing less CO2 levels. Okay, rebreathing EtCO2. Like I said, circle system, you will understand with the anesthesia machine and ventilator. But what happens in circle system is a lot of the expired gas is also given back to the patient. So here there is increasing in CO2 levels, but there is no patient. Uh, it's not a problem of patient. It can be a very ventilator related problem, or it can be faulty expiratory valve in my valve. It is a faulty expiratory valve, inadequate inspiratory flow, partial rebreathing, insufficient expiratory time. So this is more related to my ventilatory settings. So I have to take care my ventilatory settings are adequate so that I'm washing out CO2 adequately from my patient. Here also my CO2 is increasing. Okay. Shark fin appearance. This is a very important uh, n- shape of capnograph that you have to remember. You see, alveolar plateau is taken away here. Loss of alveolar plateau causes shark fin appearance. So, obstruction in expiratory limb. Patient is not being able to expire well. That will cause obstruction. There is asthma and COPD. So, asthma and COPD, they both are having narrowing of tracheal lumen, narrowing of airway lumen. So your air is not expiring out properly, and that is why uh, the obstruction in expiring of your airway gases is causing increase of CO2 levels, right? So this is bronchospasm. Bronchospasm, you might feel it's very rare, but um, it's a very common thing to happen in COPD patients and while we are giving anesthesia to a general anesthesia patient. So bronchospasm can happen and a part of my lung is not being ventilated only, right? So that is causing a lot of CO2 trapping and I'm not able to expire it well and I will go for my own treatment and treatment protocol to relieve the bronchospasm uh, in a graded format. But you have to remember that this is also causing a lot of retention of CO2 in the body. So that can lead to CO2 narcosis and it will cause a lot of other, grave issues for the patient. Foreign body in the airway. If my airway is being obstructed by something that is external to the body, that can also. Internal causes are COPD, asthma, bronchospasm, obstruction, right? And if my airway tube, the endotracheal tube that you're inserted in the mouth of the patient, that is also occluded or that is kinked. So that is also not letting the air to come out of the circuit and ventilate the patient. So that is also increasing the CO2 levels in the body. Sudden loss of ATCO2 waveform. What happens if my waveform was all well and then suddenly I see a baseline only? There is no expiratory upstroke, no alveolar plateau, no inspiratory downstroke. Why is that happening? So that should alert me always because that might be apnea and that can be cardiac arrest as well because my patient has stopped breathing, right? And airway obstruction. Okay, ma'am. All right. So sudden loss of EtCO2 will tell me airway obstruction, dislodged airway, airway disconnection, ventilator malfunction. That alerts an anesthetist to check all the equipments, all the machine-related parameters, my ventilator settings, my ventilatory tubes, and also physiology of the patient, that is cardiac arrest or apnea can occur. Curar cleft. Now, this is the shape of a curar cleft seen in capnograph. This is showing light planes of anesthesia. My patient is coming out of neuromuscular blockade. What we do in general anesthesia is we are paralyzing the patient so that only the breaths given by us, by the ventilator, is being uh, given to the patient. And the patient is not breathing on his own. For that, the neuromuscular blockade has to be very good. If it is not adequate, my patient will start breathing on his own. So that is why it is going down. The CO2 levels are going down because my patient has started breathing on his own. What will I do in this condition? I will give more neuromuscular blockade and I will deepen the plane of anesthesia. Okay? Patient should not be able to breathe on his own when I have given general anesthesia to the patient. This is curar cleft. Esophageal intubation. There is some carbon dioxide levels even in our stomach. So what if my endotracheal tube has not gone into trachea and it has gone back into esophagus? So even EtCO2 will give me a hint that it is not into the trachea. It is in the esophagus because now there is no graph, right? Slowly it has tapered down. So gastric washout of residual CO2 and subsequent CO2 will be zero. So the best way of knowing if your CPR has been successful, CPR, cardiopulmonary resuscitation, is successful is also shown by EtCO2. Now, in the American Heart Association, EtCO2 is a very important parameter, not only for general anesthesia monitoring, also for CPR monitoring, because it will tell you the quality of your chest compressions, and also it will detect the return of spontaneous circulation. Do you see? My patient was not breathing, and after adequate CPR, my patient started breathing, and this is known by my EtCO2 waveform. So poor perfusion and cardiac arrest will also be seen by my EtCO2 waveform. So this cardiac arrest we discussed that it started coming on the baseline. My patient stopped respiring, but after my CPR, my patient is respiring. So my CPR was successful and it has obtained ROSC, that is return of spontaneous circulation. Now, clinical applications of capnography, monitoring during anesthesia and sedation, verification of endotracheal tube placement, like we discussed, detection of hypoventilation and apnea, assessment of CPR quality, diagnosis of pulmonary embolism, and other airway conditions. We saw that. Okay. Now, previous year NEET PG questions. I would like to discuss some 5 to 6 NEET PG questions. What does a sudden drop in ATCO2 indicate during surgery? What will it tell you? Is it hyperventilating? No. If it is hyperventilating, there won't be a sudden drop in ATCO2. Uh, there will be a gradual drop. Pulmonary embolism, yes, it can be pulmonary embolism because suddenly a patient is having obstruction and in his in his airway circulature, and that is why the carbon dioxide levels are increasing and my patient is not able to breathe well. Hyperventilation, it will increase bronchospasm, it will increase definitely too much in a shark fin appearance. Okay, identify capnogram pattern seen in rebreathing. There is no diagram given, and they are asking you what is the capnograph pattern in rebreathing. So if patient is rebreathing, so his CO2 is given again back to him. So there will be elevated baseline, right? Elevated baseline is seen in capnograph, which is rebreathing. Okay. Normal range of EtCO2, it is 35 to 45 mmHg as we discussed. 30-year-old male patient was intubated for surgery by a final year resident. Which of the following is the best method to confirm the endotracheal tube? That is EtCO2. It is a standard, it is a gold standard monitor to monitor for endotracheal intubation. Fifth, a capnograph obtained from an intubated patient undergoing controlled ventilation is given below. Which of the following is likely a cause of the finding seen? Okay, I have forgotten to attach uh, the photo here. Wait, okay. But it had, just a minute, it had esophageal, like we discussed. Wait, I'll show you the graph. Do you see this graph? This graph was given, and so it was an esophageal intubation. Okay, all right. Summary, capnography is a vital tool for monitoring ventilation, perfusion, and metabolism. It provides a real-time feedback on respiratory status. Understanding capnograph is crucial for diagnosing various conditions. Thank you. Okay, I'm done now. Yes, I'm done with my presentation.